Hi, good evening. My name is Lorraine Karugdan. I'm your provider for today. I'm gonna do your physical assessment of the head, ears, eyes, neck, nose, and throat, as well as respiratory and cardiovascular, if it's okay with you.
Yes.
And later for the respiratory and cardiovascular, I'm gonna ask you to remove your clothing for better visualization of the area, if it's
Yes.
okay. Thank you very much. So I gathered all my equipments, I washed my hands, I closed the door for privacy, and I placed the patient in a comfortable position. First, I have to ask your name, date of birth.
Andres Carlo, July 15, 1978.
Do you know where you are?
Yes, in the clinic.
Do you know what the day is today?
September 21, 2023.
So the patient is awake, alert, oriented ×3, so no problems. Any pain?
No.
Any shortness of breath? Any chest pain? So none. So let us proceed. Vital signs are stable as well. So I'm gonna check for the hair infestations, noting for any masses, lesions, tumors, which is none. Then I will proceed with assessment of the eyes, checking for the symmetry and placement of the eyes, open and closure of the eyes, symmetry of the face, which is no problem, and color of the face as well. Cyanosis bluish discoloration can indicate cyanosis. So let's proceed with the visual acuity. So I'm gonna use a Snellen's chart. Standing 20 feet, cover your eyes, read the letters, smallest letters as much as possible.
LTFPH.
The other one,
LTFPH.
remove your both hands.
LTFPH.
So the patient can read in 20/20 LTFPH, meaning the patient is standing in 20 feet with a normal person can read 20 vision, no problem. Then I will proceed with the near vision. Using a piece of paper, read one phrase for me.
Sisters start a child.
So we're assessing here the accommodation, which is usually lesser for patients or for persons above 40. We're assessing presbyopia, which is no problems with that. And I will proceed with the Hirschberg test using my pen light. So I will turn on my pen light and put it on the 12 to 15 inches on the bridge of the nose. The light should be reflecting bilaterally on the eyes. Then I will do the cover and uncover test. So I will hold the card. I will check for the uncovered eye, noting for any deviation or movement or strabismus, which is none. Then I will remove this one, checking for the uncovered eye for any movement or deviation, which is none as well. Then I will proceed with the size of the pupil bilaterally. Pupil size is 3, which is normal. I will do the Hirschberg, I will do the 6 cardinal gazes. Follow my pen light using your eyes gaze only, not your head. No problems. Then I will proceed with the inspection of the sclera, color, which is white, and conjunctiva, which is clear, no discharges as well. Looking for conjunctivitis. Then I will do the ophthalmoscopic exam. So I will use the ophthalmoscope. So the diopter is already in 0 position. Turn it on. 0. Turn on the light. 0. I'm gonna assess right eye of the patient using my right hand. Also left eye of the patient using my left hand. Noting for the red eye reflex. Absent of the red eye reflex can indicate retinal detachment. Also, I'm gonna assess for the retina, noting for any hemorrhage or cotton wool spots, which can indicate retinal hypertension. Also, I'm gonna assess for the cupping or the disc. Disc should be lighter than the disc cup. Disc or cupping of the disc indicates glaucoma as well. The disc should be clear and the margins should be clear. The color should be pink or clear as well. Then afterwards, I'm gonna proceed with the pupil size already. Then I will proceed with my with the ear. So with the ear, I'm gonna assess using an otoscope. But first, I will use my pen light first because he's an adult. So I'm gonna pull the pinna up and back. So with that, I'm gonna assess for any cerumen, any discharges, or any tenderness, and any bleeding or blood, and color and symmetry of the ears as well. Then I'm also gonna do use this otoscope. Gonna turn it on. Here, the light is here, present here. I'm gonna put it halfway to the canal. I'm gonna check for the tympanic membrane for the color, any tenderness. Tenderness of the tympanic membrane could indicate otitis media. Also, yellowish discoloration of the tympanic membrane indicates otitis media as well. Bluish discoloration of the tympanic membrane indicates blood or skull fracture or fracture of the skull. I will also do the hearing test. So I'm gonna use a tuning fork. So I'm gonna activate it, put it on the top of the skull. So patient should be able to hear the vibration in bilateral ears, no problem. And I'm gonna do the Rhines test. I'm gonna position my place over here so that's for visualization. I'm gonna do the bone conduction first. Tell me if you cannot hear the vibration anymore.
I can't hear.
Place it 1 to 2 centimeters anterior portion of the ear. Tell me if you cannot hear it anymore.
No.
Okay, so meaning the patient has no hearing loss because air conduction is longer than the bone conduction. Sensory neural hearing loss, it means that there's a problem in the auditory nerve, where in conductive hearing loss, there's a problem of the sound waves passing through the external ear to the middle ear. Then I will do the whispers test. So I'm gonna whisper. Tell me what did I whisper?
512. 512.
So no problems with the hearing, so the patient could hear very well. Now we'll proceed with the nose, inspecting the external nose, noting for the symmetry of the nose, checking for the internal or the inside of the nares, noting for any discharges, any lesions or any foreign body. And nasal cavity should be clear, no discharge. Then I will also occlude the nares one at a time, checking for the breathing. Very good. And also I will do close your eyes. Tell me what do you smell for the smells.
Orange peel.
Very good. So this is an orange peel. I will also check for the sinuses. Gate up here, eyebrows, cheeks, underneath the cheekbone. There should be no tenderness or no swelling. Checking for crepitus. Presence of crepitus indicates exudates. Then I will proceed with the mouth. I'm gonna use my pen light and my tongue depressor. Can you please open your mouth? Okay, open your mouth. Very good. There's movement of the uvula up. Can you put your tongue up? Very good. If there is no movement of the uvula up, or a patient could not put the tongue on the hard palate or the palate, meaning there is abnormality on the cranial nerve 12, which is the hypoglossal. Also, can you please, cranial nerve 9 and 10, which is the glossopharyngeal and the vagus. Can you please protrude or stick your tongue out? Patient could stick the tongue out. Tongue should be in midline. If the patient is unable to do it, there's a problem with the cranial nerve 12, which is the hypoglossal. But before that, I will also assess for the color of the lips, which is pink. If there's bluish discoloration, it indicates cyanosis. Noting for any lesions or any sores. Lesions on the upper lip indicates herpes simplex. Also, I will ask if you're using any dentures.
No.
I will also check for any odor. Fruity sweet odor indicates DKA or diabetic ketoacidosis. Then also, I will also tell the patient to swallow. Can you speak good morning?
Morning.
Meaning I could understand and hear it clearly. So there is no problems with the swallowing, no problem with speaking. And I will test for gag reflex. Open your mouth. Open your mouth. Okay, so the patient is positive for gag reflex, no problems. And I will also check for the loss or the tenderness of the tongue. Should be different. Okay. So texture of the tongue should be all throughout the same of the tongue. Noting for any lesions using a tongue depressor. Movement of the tongue as well. Very good. No lesions, no problems. So that's fine. And the last would be the sense of taste. So tell me, what do you taste? My hands are clean.
Sweet. Salt.
Very good. So I have sugar and salt, no problems. Then after the mouth, I will proceed with the neck. So I will palpate the trachea. Deviation towards the right is normal. That's such great, the clear position. Noting for any lesions, any masses or any goiters. Noting for any discoloration of the neck as well. After the inspection, I'll proceed with the range of motion of the neck. So chin to chest, up, side, side. Do you have any pain? No dizziness. So there's no problem with the range of motion. Check for the carotid pulses. Should be one at a time. Okay. Check for the lymph nodes. Please put on the check. Lymph nodes should be done in the front of the ear, going down towards about the underneath the chin, towards the middle of the neck, clavicle, to behind the ear, going down, and the posterior portion of the head, noting for any tenderness and comparing it bilaterally. It should be non-palpable for some. And I will proceed with the lungs and the cardiovascular. Can you please remove your shirt? Inspect for any color. So I will put your privacy. Okay. Noting for any color of the lungs. So color of the chest. So there should be no pallor. So there's no lesions. Palpate for any lesions, for any masses, any tumors, which is none. Then I will proceed with checking for the lips or nasal flaring. Lips, bluish discoloration of the lips. Low oxygen or cyanosis or nasal flaring indicates air hunger, which is not present with the patient. Then I will also check for the landmarks of the chest. So we have the clavicle, we have the sternum, which is flat, and we have the rib cage, which should be apparent. And then I will proceed with the palpation of the tracheal position, which I already did, and I will do the chest expansion. So let's face the camera. So chest expansion should be done posteriorly and by anteriorly. So I'll put my hand like this, and then inhale, exhale. So it's bilateral. There is symmetry bilaterally. Very good. That is chest expansion. Then I will do the tactile framatus. So I'll place my hand on the 10th rib. I will ask the patient to say 99, noting 99. For vibration bilaterally.
99.
Very good.
99. 99.
Anteriorly.
99. 99. 99. 99.
Very good. So vibration is felt bilaterally as well. Then I will proceed with the percussion of the chest, which is done in the intercostal spaces, noting for resonance. Resonance should be heard all throughout, especially in the posterior portion of the lungs. Hyperresonance can indicate abnormality. Dullness or flat could indicate infection. Hyperresonance can indicate asthma. Then I will proceed by checking the diaphragmatic distortion. Please position yourself over here. So diaphragm usually rises towards the right because of the anatomical position of the liver. So I will palpate the second or third intercostal space, mid-clavicular line, noting for dullness. So for now, I will feel resonance. So I already feel dullness over here. I will mark it, or imaginary mark. Then I will palpate over here. Then I will measure. So it should be 3 to 5 centimeters. So anything beyond that indicates tumors or ascites, which is no problems with the patient. Next, I will do the auscultation of the lungs for better visualization for the camera. I will ask the patient to sit down. So I will assess for any wheezing, which is common to patients who have asthma. Crackle is common to patients with pneumonia, and rhonchi is common to patients with bronchitis. The Menesh and Strider, which indicates obstruction. So deep breath. Do it posteriorly as well. So the patient's lung sounds are clear. No wheezing, no crackles, no bronchi. Then I will proceed with the cardiovascular. So I will check for the color as well, inspect for any tenderness, inspect for, look for the lips, also for the color, check for any edema of the extremities, upper, no edema. Edema should be 0 or absent. +4 indicates 2.5 mm indentation, which is severe. Also noting for capillary refill, which should be less than 3. Clubbing of fingers as well could indicate fibrotic changes. Then also I will proceed with the eyes. I forgot, noting for lipid deposits or xanthelasma. Then for that, after that, I will proceed with the jugular vein pressure measurements. I will let it position over here. So I will use the measurement here over you. Very good, thank you very much. So look on the left. So I will note the highest point of the pulsation and make a imaginary angle, or known as the angle of Louis, towards the sternal notch, which is here. I will measure. So it's 3, and then I will add +5. The normal should be less than 8, which is normal for the patient. Then afterward, I will assess for the precordium. So I will do inspection first, noting for any vibratory sensation or any pulsation. So I'll do the pericardium over here, noting for any vibration, which is not upon palpation. Then I will palpate the point of maximal impulse, which is on the mitral valve, 5th intercostal space, mid-clavicular line. I will assess the apical pulse using my bell of my stethoscope. Okay, noting it for 1 full minute. Point of maximal impulse, the normal is 60 to 100 on the 5th intercostal space, mid-clavicular line or mitral valve. Then I will do the palpation of the 6 major pulse sites. So first we have the radial, the ulnar, the brachial, the popliteal, can you bend your knee? Popliteal at the back of the knee, dorsalis pedis over here, and dorsalis tibialis, which is the back of the ankle or in the ankle area. +3, the normal should be +2, which is normal. +4 should be bounding, and absent is 0. So it could indicate as well obstruction or DVT. Then I will also assess for edema, noting for the temperature, for hair distribution, because edema and hair loss could indicate PVD or peripheral vascular diseases. And I already did the capillary refill on both hands, which is less than 3, also with the toes. And the last will be the assessment of the cardiovascular sound. Can you please sit down for better visualization of the camera? But usually the patient is in comfortable position. So I will use the bell of the stethoscope or diaphragm. So I will use the bell. So I'm gonna start with the aortic, 2nd intercostal space on the right, mid-sternal border. Then 2nd intercostal space on the left. This is pulmonic valve, Erb's point, 3rd intercostal space, mid-sternal border. Tricuspid, 4th intercostal space on the left side. And the last would be mitral valve, 5th intercostal space, mid-clavicular line, wherein you can see point of maximal impulse. Noting for any extra cardiovascular sounds, S3 and S4 as well. Ventricular gallop and atrial gallop. Any questions?
No.
Thank you very much.